До нас хоче приєднатися професор Кім з Південної Кореї, президент КОМІС, це Корейська асоціація малоінвазивної хірургії хребта, і очільник, he is chief of journal of minimal invasive spinal surgery. It is the best journal in the world in this time, in this direction. Would you like it?
Hello?
Dr. Kim, we listen to you.
Good morning, ladies and gentlemen. I'm Hyeun-Sung Kim from Harrison Spinal Hospital, Cheongdam, South Korea. It is my great honor to give a lecture in the 20th International Symposium of Minimally Invasive and Instrumented Surgery of the Spine, and thanks to Dr. Letchenko to invite me. Today's my lecture is that some Uniportal spinoscopic decompression for myelopathic cervical stenosis. This is my curriculum vitae and disclosure. Yes, we already knowing that some endoscopic spine surgery evolution of the so much from the endoscopic discectomy for nowadays in lumbar intervertebral fusion. We know that the first generation of transfemoral lumbar discectomy and second generation of the interfemoral lumbar discectomy and third generation of the endoscopic decompression and fourth generation of fusion. But among them, still we need some solving point of the two to success the endoscopic spine surgery for all degenerative spine will be that some thoracic endoscopic lumbar decompression and cervical endoscopic lumbar decompression for myelopathy, and there's endoscopic application for degenerative deformity. Today we will discuss that some cervical and thoracic endoscopic decompression for myelopathic patients using the Uniportal spinoscopic spinal surgery. And the concept of the endoscopic decompression, especially not only lumbar but also thoracic and cervical, is very important. Is that it should focusing that the safety and successfulness. To achieving the safety, I always recommend that some outside in over-the-top technique. You can see here my paper of the lumbar outside in over-the-top contralateral approach and thoracic endoscopic decompression using the over-the-top technique, and the cervical endoscopic decompression for using the some outside in over-the-top technique. This is very important to keep the safety, especially in thoracic area and cervical area. Using this technique, we can safely apply to like this serious cervical myelopathic patient and like this pre-OP and post-OP like this. And technically, I already mentioned that some, especially in the thoracic and cervical area, most important will be that preserving the safety. For preserving the safety, we should keep in mind that some, as possible as we should try that some over-the-top technique and outside-in technique. Over-the-top technique means that the working, firstly, finish the or bone work from the outside and over the top toward the contralateral area over the top technique, and firstly drilling the some or bony materials before exposing the spinal cord area, then finally take out the ligament flava. This is very important concept. And also cervical also same technique using the some over the top and outside-in technique. Using the outside-in technique, we can over from ipsilateral to contralateral side, and then over the top technique and the outside-in technique. Firstly, we drill all around the bony structures around the ligament flavum, then make like this, and then finally take out the ligament flavum with the if possible by the one piece. That is a very important point to preserving the safety of the cervical area. And this over-the-top technique and outside technique, I already published a paper. This thoracic over-the-top outside technique for in the operative neurosurgery, you can see this my paper. And also in the cervical area, I also published this technique in the general neurosurgery in spine section, and you can see this outside and over-the-top technique, and remove the relevant problem by the one piece. For example, like these cases, in the cases like two-level decompression patient, like this patient, 47-year-old male patient with myelopathy and weakness, the patient needed decompression, this two-level. In this situation, drilling the or outside of the ligament problem area of bony structures using the over-the-top outside-in technique, and making the bony island tree here and take out the ligament problem finally, then we can see like this post-operative safety decompression for this patient. In the situation of the cervical myelopathy, we can consider the several concepts. Some of patients need only unilateral decompression single level, and then possible contractile decompression can possible without bony drilling. But some of patients need a bilateral bony decompression in the cases of more serious myelopathic patient. And also some of patients need a multi-level decompression like this unilateral decompression. Sometimes you can see here the bilateral decompression needed, then meaning that the bilateral laminotomy also together. And also thoracic also same situation. Thoracic usually in need some single level decompression, but in the cases of multi-level cases, sometimes in need some separate drilling, but some cases need a total resection, maybe sometimes needed bony structures. For example, like using this over-the-top technique, you can see like this, go to the contractile area, then we can make like this ipsilateral decompression sufficiently by two level, and you can see here the contractile decompression also done. And thoracic area also can possible doing the separate decompression, but sometimes it may be needed some total decompression may be needed. And the operation procedures, you can see here some docking the medial border facet, and if it's possible in the thoracic and cervical area, sufficient laminotomy of the ipsilateral facet area to achieving the sufficient decompression. Because of that, in the cervical and thoracic area, endoscopic decompression usually sufficient preserving the tensegrity. Because of that, the instability usually not happen. Because of that, sufficient laminotomy of the ipsilateral side and going to the contralateral side using the drilling, and in the sufficient ligament problem detached from the cranial to caudal and contralateral side done, the laminotomy should processing and finally take out the ligament problem like this way, like this. And also cervical also same situation. Using this technique, you can see here the cervical three-level decompression of 3, 4, 5 version and ligament problem here. This lamina and all ligament problem take out by the one piece, and also thoracic and lumbar also can possible like this one block resection is possible. Now, for achieving this operation, we need some sufficient good endoscope system with some small scope and a large scope. And the more important instrument will be the good endoscopic drill. Good endoscopic drill is very important in the cervical and thoracic area, and also some soft tissue manipulation system of radio frequency system using this thin radio frequency system and this thick radio frequency system also together needed to manipulation of the soft tissue manipulation. And also another advantage of the endoscopic spine surgery, I already mentioned that you can see here the skin incision of the two-level cervical decompression patient. All structures preserved completely without muscle, but also skin control also preserved completely. it meaning that the tensegrity of structures, human body structures preserved completely. That means that in spite of some biomechanical mild instability cases of the cervical area, thoracic area, with only decompression is sufficient to preserving the patient decompression and the patient stability. It means that in the cases of the mild instability cases also, decompression is sufficient to patient problem solving. That is important to patient preserving the motion and making the return to his activity to normal life. That will be very important point. Our last 3-year Harrison Spinoza Hospital history, we performed about 120 cases of cervical decompression and 110 cases of thoracic decompression for myelopathic patient, and all patients achieved excellent clinical result. And I will show the cases. Firstly, I will show the cases of thoracic decompression cases with the myelopathic cases. My paper talking that always keep in mind that some over the top outside technique for the safety. For example, this patient is very young, 31, male patient with back pain and mild weakness and occupied ligament problem of the T5-6 area. Using this intraoperative view, you can see firstly during the facet area, then during the cranial part, and if possible, drilling as much as possible to detach the tip of the calcified ligament problem of the cranial parts, and sometimes caudal parts, and sometimes contralateral parts. Then you can see some outlined part of the occupied ligament problem here, and you can see here midline, ipsilateral supra process here. And here is the contralateral side. And now going on over the top contralateral side. Then more drilling to the contralateral side. Then you can see some final point of the calcified ligament problem and detach from the dura. And you can take out occupied ligament from inside out manner. That also very important. If it's possible, lifting, not using the punch, not using the push, that will be very important. And you can see finally to the contralateral side, occupied ligament problem final parts. Again, lifting and take out the occupied ligament problem here. And finally, you can see the sufficient decompression. And post-operatively, you can see these operation procedures, post-operative, and final, the patient take excellent clinical result. And also, this patient is 83-year very old female patient with some weakness. Using the over the top outside technique, you can see all drilling from the outer area. Then finally take out the ligament problem. After that, you can see this image, and the patient also have a great chance to return to his motor weakness recover completely. This 1-year follow-up. And also, there's some cases combined with severe stenosis of vertebral with some so huge disc tree here. In this situation, firstly decompression, and then using the large scope, and then change small scope and remove the calcified disc again, and finally checking the code dura, and then you can see sufficient decompression was done. This another cases of the central decompression with the calcified disc together. This patient also 38-year patient, also very severe weakness, but after decompression you can see some calcified disc, this decompression of over the top outside technique, and change the small scope and drilling the calcified disc in the intralaminar approach way. In this situation, we should making the sufficient space of the lateral part of the cord, then insert the small scope, and then drilling this calcified ligamentum, calcified disc. And finally see that some sufficient decompression was done. Calcified disc. And 1 month later, the patient weakness recovered so much, and also post-OP, and 6 months later, the patient motor weakness recovered so much, and also you can see the decompression was achieved sufficiently. These are other cases of the so serious myelopathy due to the ossified ligament problem of the 64-year-old female patient. In this situation, maybe if the patient need a open surgery, maybe need a fusion surgery with still some constant of the weakness. But using the endoscope decompression, post-operatively, this preoperative, this post-op image, and also this 1 day, this 2 day, this 3 days later, the patient's weakness recovered so rapidly. And also 6 months later, the patient's MRI showing that the myelopathy and spinal stenosis recovered so much, and also the patient walking recovered near completely. And now we will see some cases of the cervical myelopathy with stenosis. And also you can see this is my paper of the Journal of Neurosurgery Spine, published this year. And this is my technique. And the first case, we can see the 80-year-old female patient with some weakness and cervical myelopathy. You will see firstly drilling the ipsilateral facet and IAP. If possible, sufficient decompression they need, and now going on to the contralateral side. Firstly, work should done by the drilling for the tip of the ligamentum flavum, attach point of the ligamentum flavum from the bone structures. You can see here there's some ligamentum flavum, and then finally you see there's some detach point, and then finally take out the ligamentum flavum here by the one piece. This is very important to preserving the safety in the cervical area. Now you can see the sufficient decompression was done, and the post-operative you can see the decompression is successfully. This another case is with some myelopathic patient. The patient need sufficient decompression for this patient. In this situation, intraoperative, you can see the some standard point decompression sufficiently, and post-operative image showing the sufficient decompression was done, and 1 year follow-up, the patient standard decompression was preserved sufficiently. The patient also recovered so much. This another cases of the single level decompression with the myelopathy of the 55-year-old male patient with weakness, and also this patient also sufficient decompression was done. But in this situation, I done much laminar drilling to the contralateral side, and also 1 year. 6 months later, you can see the some spinal cord decompress very successfully. This is another cases of 64-year female patient. You can see the so serious spinal cord compression with serious myelopathy. And also in this situation, using the outsiding over the top technique, you can see the real good clinical result to the patient without fusion surgery. This patient looks like fusion surgery, but after post-OP, you can see the sufficient decompression. And this patient also follow-up the 1 year, the patient result is very excellent without instability. This another patient also looks like similar of the C4-5 level, upper level also can give the safety surgery using the outside and over the top technique. You can see using the same technique of the outside and over the top technique, you can see decompression sufficiently. I'm also doing the sufficient laminotomy because of this patient preoperatively so serious spinal cord swelling and compression. And also another case is also the myelopathy patient also post-operatively imaged by the 2-level decompression. and by the bony island making the some removal of the ligament problem by the one piece. And post-op, and this another cases of myelopathy with 49 old male patients. And the post-op MRI, you can see the single level laminectomy and bilateral decompression was done. And 1 year follow-up, you can see the very excellent decompression was done. This another cases of two-level decompression cases with a myelopathy patient. This patient also same making the bony island take out the ligament by the one piece. But in that situation, to decreasing the postoperative fluid collection and the hematoma collection, I insert the drain so much because of that it can remove the 1 or 2 days later, and there is not damage to the structures. And also, you can see postoperative image. And also, 1 year follow-up, you can see the excellent clinical result. You can show this image. This is another cases of, you can see the C2, 3, 3, 4, but higher level of cervical myelopathy patient also can take excellent clinical result using this over the top outside in technique. And this another case is serious myelopathy patient. And in this situation, I'm doing the sufficient laminectomy, not only ipsilateral side, but also contralateral side together, only by the Uniportal, one skin, over the top contralateral approach. And then 1 year follow-up, you can see the patient clinical result, very excellent. The patient at the initial time, walking is very difficult, but now he returned completely normal life. And this another cases of 4-level decompression cases also can possible by the single level, single incision over the top outside in technique. You can see the post-operative image, sufficient decompression was done and sufficient laminectomy, not only ipsilateral side, but also contralateral side was done. In conclusion, during last 3 years, Harrison Spinach, such from me and Dr. He, we 2 doctors, we performed about more than 4,000 cases of the endoscopic spine surgery for all cases of degenerative spinal disease. Among them, most important point will be the successfully performing the cervical and thoracic myelopathic cases and lumbar deformity, degenerative deformity, rheumatoid fusion cases. In this, my hospital clinical result showing that some cervical surgery and thoracic surgery over more than 12% among all operation, thoracic and cervical. It means that successfully performing the cervical and thoracic myelopathic decompression will be the very important portion of the achieving the successful endoscopic spine surgery for all degenerative spinal disease.
Thank you very much.
President of Korean Minimal Invasive Spinal Surgery, I'm a president. This year, Commiss will hold the first World Spinoscope Congress. At this Congress, already 25 famous endoscope society will join, and they already accept. Please join to this meeting, and that will be your next generation.
Thank you very much, Dr.
Thank
Kim.
you for your
I
kind
hope the emblem of Ukrainian Spine Society also will be in your slide the next time, yeah? And the next presentation also from Dr. Kim about interbody fusion of degenerative deformity. Please.
Good morning, ladies and gentlemen. I'm Hyeun-Sung Kim from Harrison Spine Arthros Hospital, Cheongdam, South Korea. It is my great honor to give a lecture at the 22nd International Symposium of Minimally Invasive and Instrumented Surgery of the Spine. And thank you so much, Dr. Vladimir Radchenko, for inviting me. This time, my lecture topic is that Uniportal Spinoscopic interbody fusion for degenerative deformity. Currently, I am a president of Korean Minimally Invasive Spine Surgery Society, Commiss, and editor-in-chief of Journal of Minimally Invasive Spine Surgery and Technique, JMIST. This is my curriculum vitae and disclosure. Today my topic is that endoscopic, spinoscopic transperineal lumbal fusion. This is illustration for endoscopic, spinoscopic uniportal transperineal approach. And during last 3 years, Harrison Spinartus Hospital has about more than 560 cases of rheumatoid fusion using the spinoscopic approach, transperineal approach for uniportal and biportal. Among them, more than 100 cases is more than true-level cases, but fortunately, more than 450 cases performed under the epidural anesthesia. We already knowing that the endoscopic approach rheumatoid fusion has several advantages compared to the open surgery, but we can remind that some uniportal spinoscopic transperineal approach has an advantage that some firstly it has a single port corridor is possible. Second advantage is that it has a mechanical tensibility, and the third minimal invasive profile, and fourth direct visualization, and fifth anesthetic flexibility, and finally structural preservation approach is possible. In the spinoscopic transperineal endoscopic interval fusion, there are several technical tips. Firstly, it has a great advantage of technical tip is that first adhesive disc drilling. Second is end plate denudation. And third, double cage insertion is possible. Fourth, anterior cage, angled cage insertion is possible. Angled cage. Then fifth, osteophyte drilling is possible. This is also very important. Sixth, atlas cage insertion technique is possible. Bilateral wedging point cage insertion technique is possible. And the seventh, Harrison cage, using the Harrison cage glider, it can protect the ejecting nerve root and traversing nerve root together. And using the 3D printed cage, it has a great higher chance of fusion rate and a low chance of substance rate. Firstly, in the adhesive disc drilling, meaning that the drilling the adhesive point of the disc area, it has a very big advantage to increasing the disc height restoration, not only, but also it has a very effective restoration of spinal alignment by naturally. For example, this case is L5S1 after operation. You can see the sufficient disc restoration and also sufficient angle correction is possible. And the second technical tips of endoplate denudation, this is also very important, is that this only splitting the endoplate from the vertebral body. It has a, in my paper, using this technique, it has a very rapid fusion process and low rate of substance rate. And also, third technical tips of the endoscopic, spinoscopic rheumatoid fusion of the it can possible insert double cage insertion is possible. For example, first insert like this angle, first insert this angle, and second insert this angle. Like these cases, you can see the L5S1 insert the bilaterally, and good angle correction and good bilateral biomechanical stabilization is possible after endoscopic, spinoscopic rheumatoid fusion. Third technical tips, it can possible insert angled cage insertion is possible. Unfortunately, in the conventional open surgery, in the posterior approach, the angled cage insertion is very, very difficult. Because of that, many doctors, they convert to the anterior approach to insert the angled cage insertion. But in the spinoscopic rheumatoid fusion, it make a sufficient segmental restoration after chronic adhesive disc drilling, meaning that the angled cage also can possible, insertion is possible. You can see here, this case pre-op and post-operatively, you can see this 12-degree and this 12-degree angle insertion is possible. Also, currently, I use the 16-degree, maximum 16-degree angle cage insertion is used. And also, Next technical tips is osteopathic training. For like this case is maybe this kind of restoration is very difficult in the posterior approach, but also anterior approach also not easy. But on the in spinoscopic endoscopic rheumatoid fusion, we can drill this area under the view. Because of that, after operation, you can see like the great restoration is possible. This is a very big advantage of the spinoscopic rheumatoid fusion. And also another next technical tips of atlas cage insertion technique, meaning that bilateral right side left side zigzag insertion can make a scoliotic correction is very effectively. For example, this preoperative image and post-op image, you can see the scoliosis corrected very effectively using the atlas cage insertion technique. And seventh technical tips is using the Harrison cage glider. Harrison cage glider developed by me, and it protects the bilateral ejecting and traversing nerve root together. For example, insert like this way and rotate, protect the ejecting nerve and ejecting nerve root and traversing nerve root together. Because of that, cage insertion using under the Harrison cage glider with the big cage insertion also very safe for using this cage glider. And the final technical tips is we can insert using the 3D print cage. We already knowing that the 3D print cage has higher chance of fusion rate. Among them, more than it has we can use the large angled cage insertion is possible. Currently, I use the 15 discrete to 16 discrete with the 16 angled cage insertion cage is possible. Using these techniques, we can have several advantages of in the spinoscopic endoscopic rheumatoid fusion. For firstly, single posterior corridor, second, alignment correction, third, biomechanical tensegrity, next, minimal invasive profile, and direct visualization, anesthetic flexibility, structural preservation, and easy revision surgery. Firstly, in the single posterior approach corridor, because it only approach only single corridor, it has a big advantage that decreasing the muscle damage and percutaneous screw, rheumatoid fusion, and additional decompression, all performed by under the this single posterior corridor. Because of that, this is a real minimized option of the spinal surgery, and in spite of the complex region, it can easily solved using this posterior Uniportal spinoscopic transfemoral rheumatoid fusion. Second advantage is that the powerful alignment correction. I already mentioned that using the chronic adhesive disc drilling, you can see this segmental correction, coronal correction, all very effectively using. You can see like this here. And also, third advantage is that the biomechanical tensegrity. Tensegrity meaning that all structural preservation is possible. Because of that, not only muscle but also ligament but also skin also preserved completely. Because of that, it has a natural keeping the stability or natural keeping the brace by the human body is possible. It meaning that the spontaneous restoration effective will be very effectively. You can see here the using the biomechanical tensegrity, the patient follow restoration is very good spontaneously. And the next profile is a real minimized option of profile because of that minimizing the blood vessel and avoid the psoas muscle damage, retroperitoneal damage, and the major organ damage like vessel, and also it is a real chance of the return to normal activities more rapidly. And the fifth advantage is the direct visualization. This is very important in the spite of that the chronic adhesive disc drilling is possible and the plate denudation also possible using this direct visualization. And also that has advantages that anesthetic flexibility. So many my cases, more than 80% under the epidural anesthesia. It means that this is very feasible under the epidural anesthesia or spinal anesthesia, and this really reduces the systematic complication. This is also very advantageous shorter recovery from surgery to normal activity. And the seventh advantage is real preservation of structural preservation. This structural preservation, not only muscle but also fascia, skin, all structures, give the real chance of biomechanical tensegrity and also real chance of spontaneous restoration and the real chance of biomechanical stability. And also, next final advantage is this endoscopic lumen interval fusion is a real minimized option. Because of that, in the cases of revision surgery, the revision surgery also not difficult to compare to the conventional open surgery. Because of that, the endoscopic spine surgery really preserve near all structures and more easy to search near normal structures. Using these several advantages, we can see the very interesting cases of deformity cases. You can see this case is 72-year-old female patient with a failed back surgery patient. This patient already received 2-level decompression, but so severe collapse, so severe kyphosis because it needs a large angled cage insertion is needed. But for this purpose, many doctors will try to the anterior approach. But in the endoscopic lumbar interval fusion, we can possible in the posterior approach. You can see postoperatively you can see the discard restoration, angle correction near completely, and also follow the alignment corrected spontaneously. 2-year follow-up result, the patient showed the excellent clinical result. This another cases of belly back surgery, deformity cases also. You can see the very, very disaster cases after belly back surgery. But using the endoscopic view with us, we can insert cage to here and to here after screw load removal, and after that you can see the post-operatively, you can see the scoliosis corrected very effectively, and 1 year later, the patient alignment corrected spontaneously very effectively. And also another case is belly back surgery case. 67-year-old male patient also. This patient also degenerative scoliosis after belly back surgery. Not only here this level, but also in the this case is L4-5 foraminal stenosis, L3-4 central stenosis combined together. But because of that, after operation, the patient inserted 2 kg above 2 level, and then decompression 3-4, L4-5 foraminotomy combined together operation is all possible. And also 1 year later, the patient alignment more corrected spontaneously. This is interesting case, degenerative kyphosis cases. These cases, I personally believe that endoscopic, spinoscopic lumbar interval fusion has a advantage of the spontaneous restoration with the keeping the biomechanical tensegrity. This preoperative image and postoperative, you can see the degenerative kyphosis, but after operation, you can see immediate post-op, but 6 months, 3 months later, 6 months later, 1 year later, the patient alignment corrected spontaneously. This another case is the deformity cases also can take excellent clinical result after 1 year follow-up. The patient still have a very keeping the stability with the multi-level posterior approach. This another case is 85-year-old male patient with the degenerative deformity. After operation, you can see the spontaneous restoration and the 6 month, 1 year follow-up spontaneous correction done. This also another interesting case is there is a very advantage that some endoscopic lumbar fusion cases because of that this patient 72-year-old female patient already received the brain surgery and so severe deformity, so severe back pain. Because of that, the patient general big surgery is very, very difficult for this patient. But using the endoscopic lumbar interval fusion, you can see here the operation time and about 5 hours with after operation. The patient scoliosis corrected very effectively. The patient also walking is very good, and patient pain also reduces so much, and spontaneous restoration also done. And this is also another case. In this case is 76-year female patient. This patient received the deformity surgery from another hospital and came with me near complete pelagic state. You can see here. This due to the T12L1 huge disc and junctional problem. You can see the both the neoplastic, but I tried to remove all load and the cage insertion only single level. You here, but endoscopic lumbar interbody fusion has a spontaneous restoration effect of the alignment. You can see here, 1 week later, and after the patient walking, 2 weeks later, the patient walking, 4 weeks later, the patient walking, and 6 months, 4 weeks later, and 3 months later, and 6 months later, and 1 year later, the patient alignment not disrupted, preserved completely, and 6 months later, the patient came with my clinic with the walking by spontaneously by herself. Yes, in conclusion, lumbar interbody fusion is still some debate portion of the degenerative spinal surgery, but I believe that the endoscopic spine surgery did already overcome so many problems and now give the so good clinical result. You can see the so serious deformity surgery has a big advantage using the spinoscopic lumbar interbody fusion. Not only minimize the option, but also biomechanical stability and but also preservation of the all structures with the spontaneous restoration effected by patient themselves. As a president of Korean Minimal Invasive Spine Surgery, I'm announced that this year, November, Komis have a first World Spinoscopic Congress. In this Congress, more than 25 endoscopic society will join to hear, and please join to hear. Thank you for.
Thank you very much.